I welcome you all back after the post-lunch session. For the post-lunch session, we have the judges, Dr. Manish Kumar, and the second judge, Mr. Rohan Rajroy. They both are here. I welcome you back, sir. And I request Madam Krishna Bhuvaneshwari to start her presentation. Judges, that number is IS1, faculty category.
Good afternoon, everybody. Good afternoon, madam.
Good afternoon, ma'am.
Am I audible? Can I share my screen, madam?
Yes, please.
My screen is visible, no?
Yes, ma'am.
Yes, so good afternoon to all the dignitaries and the judges. This is Dr. Bhuvaneshwari Krishna from Department of Biotechnology, Srimati Chandibai Himatmal Mansukani College. I've done a small study on comparative docking of phytoligands with G alpha subunit of G protein. So my interest or topic for this small study is on G proteins. So what are G proteins? G proteins are small proteins which are heterotrimeric in nature, and they act as molecular switches. They are composed of alpha, beta, and gamma subunits, and they play a very critical role in GPCR signaling pathways. GPCR is G protein linked or coupled receptor signaling pathways. They function through GTP, GDP conformations. So just to give, and they are extremely essential for cellular signal transduction pathways. So this is how they look like in the cell. These are the G proteins in the G protein coupled receptor in the cell membrane. These are the three alpha, beta, and gamma G protein complex attached to it, to which to the alpha subunit, the GDP and the GTP alternatively attach and thereby activate or inactivate the G protein. And upon activation, they migrate and they contact the nearby membrane systems, enzyme systems, and they give rise to secondary messengers. So in the picture below, the different roles of G protein coupled receptor with different classes of G proteins are depicted, which give rise to different types of secondary messengers and the pathways forward. So, what is the clinical significance of this? It has been found that aberrant or dysregulated G proteins function is linked and directly implicated into multiple diseases and disorders like cardiovascular diseases or metabolic diseases or oncogenic disorders. So basically, directly they become high value therapeutic targets, and using structure based drug design, there is a very high potential that we can discover or get new leads for these target molecules. And these G proteins, therefore, are important links for next generation drug development process. So the rationale and the gap analysis here is that the heterotrimeric G proteins are coupled to receptors called as GPCRs.
Ma'am, you can switch on your video while speaking.
Yes, sir.
You can switch on your video.
Sure. Sir, yes, sir. Am I visible?
Yes, ma'am.
Am I visible, sir?
Yes, yes.
Yes, yes, ma'am.
Yeah. Just a second. Now that view changes, I think if I use the different tab. Yeah. So heterotrimeric G proteins are coupled to receptors which are called as GP, targeted by roughly one third of FDA approved drugs. So the GPCRs are targeted by most, one third of the drugs that is found in the market. But the G proteins which are coupled to them are very less explored. These are comparatively underexplored. The direct targeting of G proteins, and therefore a study on this G protein as a direct target can give us leads which can probably give us a future drug for diseases like cancer, cardiovascular disorders, and other dysfunctions of the body. So, what is the aim and the objectives? The aim is to identify suitable phytochemicals that can be candidates for docking studies from PubChem. Docking of these shortlisted phytochemicals with G alpha subunit of G protein is another objective, and to be able to identify suitable leads for further use potential drug candidates for further analysis. What is the research methodology I used? The study focused on the G alpha subunit. The PDB number is given there, 6NE6 underscore A. This was downloaded from the RCSP PDB website. This was cleaned and prepared for docking studies using Pymol. There were about 30 phytochemical ligands that were selected from PubChem and converted to the SDF format. So on one end, I prepared the ligand. On the other end, I prepared the protein target molecule. So these 30 phytochemical ligands in the SDF format and the prepared target molecule were loaded on the PyRX software, which was utilized for molecular docking studies. And the results that was obtained after the docking were downloaded in the CSV file and later converted to Excel file for data analysis. The systematic evaluation of the binding properties and was done, and interpretation and conclusions were drawn on the document. So basically, the docking parameters, which are the docking parameters that have to be prioritized for analysis? At least in my case, I use this. I use the RMS root mean square deviation, LB, the lower bound on structural deviation to indicate minimal deviation, and RMSD UB provides an upper bound on structural deviation useful for assessing stability. So both stability and minimal deviation from the benchmark reference compounds were used for understanding how good the ligand is fitting into the
Ma'am,
active
kindly
site
move
of
to
the G
the
alpha protein
conclusion
target.
slide.
Yes,
Ma'am?
ma'am. Yes.
Yeah.
Okay, so these are the results. Out of 30 phytochemicals that was used, uh, I found about 10 of them with binding affinities in RMSD UB. This is a picture of how this docking representative picture. This is G alpha and the molecule scutellarian, which showed the maximum binding, minimum binding threshold of minus 8.67 kilocalories per mole. So out of 30 ligands, all of them scored at least in one trial 0. Then ligands exhibited superior binding affinity, which indicates potential for further use. So this is a summary of this. Out of 10, I got superior affinity. I'll skip this slide. Further analysis of this 10 molecules using drug discovery visualizer will be done, and detailed interaction of profiling is needed for understanding lead optimization and drug candidate refinement. So successful identification of 10 candidates been done by this small amount of work that I learned during the workshop. These are the references. Thank you so much.
Judges?
Hello, ma'am. Like it was a really good presentation, and based on the mostly on the immunoinformatics part and the informatic
Thank you,
part.
sir.
So, I would like to ask you, did you do the receptor ligand interaction study to determine the binding affinity scores? Hello.
No, no, I couldn't do that, sir. I
Okay,
should have
so
done as a benchmark.
yeah.
Yeah, but I couldn't do.
Okay, so like how are you saying that some of them are like showing out of the 30, 10 are showing good binding affinity compared to the others? That was based on.
Because of those, because of the binding affinity values which I showed
Okay,
you. Anything less than
okay,
minus
so
7 is supposed to be a good fit,
okay, so you
and
did
the
not do the
RMSP values.
receptor ligand interactions. You didn't do
No, no,
like you can go ahead
I
with
have
that
not.
part. That will add
I
more
will do
value.
that.
Yeah,
Yes, sir,
yeah.
I will do that, and I will further process this project.
Yeah, so if you like modify a bit and do some receptor ligand interactions, it adds value, and it will also like whatever work you have done, it will accelerate a publication or kind of. Oh,
Yes,
thank you, ma'am.
yes, sir. Thank you so much.
Ma'am,
Can I stop
ma'am,
sharing?
I would like
Just
to
a minute, ma'am.
oh, ma'am, one question from my side only. What is the purpose
Yes,
of docking phytoligands with G alpha subunits for G protein? Why you was using this aim? Why you are taking this aim?
latch on to the G alpha subunit and may give us a way of controlling and regulating.
Okay, thank you, ma'am.
So that was the idea behind phytochemicals, because phytochemicals are easily obtainable, and there is a wide diversity of phytochemicals available in nature, due to which the diversity of the compounds available helps us to get to a lead molecule faster and probably better.
Yeah, thank you, ma'am.
Appreciated, ma'am. Thank you so much.
Thank you, ma'am. I'll stop sharing, ma'am.
Yes, ma'am, please. Miss Kushi, Miss Akanksha. Miss Kushi, are you there? Yeah, Kushi Solanki and Akanksha.
Yes, ma'am.
Yeah, yeah. The screen is visible. You switch on your camera too.
Ma'am, actually, we are using our mobile, so the video is off automatically.
Judges, is that okay?
Okay.
Why the video is off automatically?
So there is a feature in this mobile, like in every Zoom meeting when we are attending in the mobile, the video is automatically off.
Okay, I have never heard like it gets off.
So
You
you
can
can
continue
try.
without the video. Yeah.
Okay. Good afternoon, everyone. I am Khushi, and along with my co-author Akanksha from Department of Microbiology, Bhavans Vivekananda College. So our title over here is Artificial Intelligence in Human Eye Health: Predictive Insights from Machine Learning. Having a quick view on the roadmap of our presentation, starting with the abstract. In simpler terms, we used artificial intelligence on CDC vision health data and found out boosting methods predict risk more accurately. Vision is not just a sense, it's independence and quality of life. Today, over 2.2 billion people live with vision problems, and at least a billion
Excuse
people.
me, Kushi. Are two people speaking here or one person is speaking?
Two people, ma'am.
No, that cannot happen. Only one person has to speak.
Okay, we didn't knew about this. I'm sorry, ma'am.
Please
Should I
continue now.
Uh,
Yes.
Okay.
I think Meena ma'am, just to note,
Yes.
they
Yeah.
both have registered, but we were not aware actually both will be speaking in the meeting.
We
Uh,
can have one of them speak, na ma'am. That's okay.
Actually, but if they have prepared accordingly, then we can consider them if they have prepared.
The
yes,
judges can take the call.
Yeah, they can go ahead with if they're prepared in that manner, they can go ahead. But yeah, they can.
thank you, ma'am and Suresh. Okay.
Checked. No issue.
So today, over 2.2 billion people live with vision problems, and at least a billion cases could have been prevented. Risk factors like diabetes, smoking, and lifestyle are well known, but underused in prediction. Moving further, we have a visual image that summarizes major risk factors like diabetes, smoking, age, and lifestyle. These are the variables we considered. These are the previous studies done in the field, and they highlight how much potential there is for applying AI in the vision health. Moving further, like our main objective for this presentation and paper was to test whether AI models can predict vision risk for the behavioral data using behavioral data, and then we also had an objective to compare all the a broad set of models to see which approach works best on this. And the main one was to give potential, like highlight the potential of AI. Our questions were simple. Can AI predict vision risk? Which model works best? And can this actually support preventive care? We hypothesized everything and was like we hypothesized was that the boosting models like cat boost, xg boost, and light gbm would outperform the traditional classifiers. Our data set came from the CDC Behavior Risk Factors and Visual Health Survey. We first cleaned the data, filling missing values instead of dropping them, scaling numbers, and handling categorical features carefully. Since our vision impairment cases were fewer, we balanced the data set so the models wouldn't just predict the majority healthy class. We then split the data 70% for training and 30 for testing. Next, we trained a range of models from traditional ones like logistic regression, SVM, and KNN. Then we finally evaluated them using accuracies as well as precision, recall, and F1 score. Moving further, we talk about results. Accuracy, precision, recall, F1 score were all considered, but accuracy is what gave us the overall picture. Like you can see, logistic regression scored very lowest and stated that the linear models aren't enough. We need to work further on it. So we worked on SVM, which was also not enough because it only gave 68% of accuracy. And then we worked on KNN and random forest, which both gave the same accuracy or the result, which we can say, which was around 75%. And we also worked on other models to find out to have a broad perspective. That was XGBoost and LightGBM. They performed around 80%, and the one which gave us the best was the CAT boost, which is also known as the categorical boost that led us to the 82%. Moving further, we have graphs. We only chose the graphs which has the higher accuracies to show how they predict and all. So starting with the random forest, on the top left corner, we have confusion matrix. So on x-axis, we took it like x-axis is about prediction class and y-axis is about actual class. So top left is about true negatives, top right is about false positives, and bottom left is about false negatives, and bottom right are true positives. So this graph basically we need to be more concerning about the false negatives as uh, as those are the ones which we need to be looking forward. If they are giving the wrong results, we can't afford that, and we can take a look on the true positives as they are valuable. For the ROC curve, we can see that x-axis is false positive rate, y-axis is true positive rate, and we all know that the diagonal line talks about the random guessing. And as we can see, the our curve is near the top left, so our model worked a bit better than the other models which we performed. Moving further, we have the other model, light GBM. So light GBM confusion matrix show fewer misclassifications than the before one. And it showed more true positives. That is why it landed the accuracy near or around say 80%, 79 to 80%. Light GBM is fast and efficient, which was also shown in the ROC curve. The main slide of our presentation is CAT boost one, because this CAT boost confusion matrix shows the largest true positive block and noticeable fewer false negatives. they directly their accuracy was around 82%, which tells us that this model had worked better than the other previous ones. Here is the quick comparison of the three models. We also
You will have
tested-
to go to the conclusion now. Huh?
Yes, ma'am, it's all. So after the discussion was nothing but talking about the whole thing, what we talked about, and moving further for the conclusion, we concluded that the boosting models did outperform all the traditional methods for predicting the vision risk from the behavioral data, which was our data set, which we took. And the CAT boost performed the best, as we can see in the graph as well. And the effective screening was to layer the this can be used to effective screening to layer and prioritize patients for timely clinical follow-up. Like we can use it as the early diagnostic methods and all. So this is what our presentation is, and these are the differences which helped us. Thank you.
Judges. Now you all can, girls, switch on the video, please.
How can the machine learning improve the early detection of any common eye diseases like glaucoma, muscular degeneration?
Sir, can you repeat the question? So after the machine learning, it was blurred. Can you repeat the question? So after machine learning, we couldn't hear.
My question is, how can the machine learning improve the early detection of common eye diseases like glaucoma, muscular degeneration, or any irritation? And the second
So
one is any ethical consideration is in this project.
So I guess they can use their medical redox results and all to use it as a data and not with the previous ones and all their previous results and all, they can use those data for the detection of coma as well, because they can predict like how long for a person with these all symptoms take to recover and all. I feel that is the one. Maybe.
Need to understand more about this. I will
Yeah.
be in contact with you in future. Thank you.
Thank you, sir.
Yeah, so as sir told, like you need to go into the ethical backgrounds of this, and you need to explore a bit more regarding what sir said. So yeah, that's a very valid point. And I would like to ask one methodology question. So basically, like what kinds of algorithms did you use in this proposing this? Like you told about random forest, and what are the other algorithms?
So we used XGBoost, Light GVM, and the basic like the traditional ones as well, like KNN, SVM, and logistic regression. Like we didn't just go with the traditional ones. We tried to work through with the machine learning models itself, because those are not that discovered. Everyone chose deep learning models when I went through the research and all. So I thought, why didn't they work with the machine learning ones? So I just wanted to know what are the different, like we started with fewer models, but we didn't get much good accuracy because of the data set imbalance and all. So we worked with the other models as well.
Okay. You can also go ahead with certain simulation based data sets or simulation metrics and all. Yeah. So yeah, thank you.
Thank
Well
you.
done, Khushi, Akanksha.
Yes.
Keep it up. Next participant is Shambhavi.
Yes, ma'am.
Yeah, please join, present.
Yes, ma'am.
Switch on your video too.
Yes, ma'am. Good morning, everyone. Good afternoon, everyone. Actually, I am Shambhavi Pathak, an undergraduate student from Amity University, Ranchi. Today, I am going to talk about the artificial intelligence in inflammatory bowel disease.
Your slide in slide mode.
Okay, so inflammatory bowel disease or IBD mainly includes two conditions: Crohn's disease and chlorotic disease. Okay, it is a long term illness that keeps coming back and makes life very difficult for patients. The problem is increasing worldwide, and earlier diagnosis is very important. Right now, doctors use tests like endoscopy and histology and imaging. These are helpful, but they take time, and sometimes results depends on the doctor's experience, which means mistakes can happen. IBD in AI in IBD. This is where artificial intelligence or AI comes in. AI can.
Sorry, Shamvi, to interrupt you, but I
Yes,
think you
sir.
have shared wrong window. Yeah, now it's okay. It's not in full screen, that's why.
Okay, sir. Sir, it is visible.
Now you are on right slide.
Okay, sir.
Beta, put it into presentation mode, na slideshow. Can you do
Is
that?
it?
Is it possible?
So, ma'am, I have put it in a presentation mode only. Is it visible?
We go
So
up to on the top, there is slideshow. Can you see on the top next to that blank? Yeah, go
I
up, go
don't
up.
see. Okay. Okay. There is where artificial intelligence or AI comes in. AI can look at endoscopy imaging and find signs of ulcer or swellings. It can also study biopsy slides from patients and tell how severe the disease is. AI can check MRI or CT scans and give results that are more constant. It can also read clinical records using natural language processing and predict which patient may face a disease flare. Patient now a new transformer based models can combine many types of data like images, lab results, and even genetics to give doctors a full picture of the patient. Studies now results and discussion. Studies show that AI improves accuracy and reduces human error. It saves time and helps doctor make faster decisions. It also allows doctor to personalize treatment by dividing patients into mild, moderate, or severe groups. But there are still chances like making sure data is reliable, addressing ethical issues, and testing these systems properly before using them in the hospital everywhere. Conclusion and future directions. To conclude, AI is not replacing doctors. Instead, it is a tool that supports them in making better and faster decisions. It can move it can move treatment from reactive, where doctors wait for problems to appear, to proactive, where problems are predicted earlier. This will help doctors give more accurate, personalized, and patient friendly care in future. Thank you for listening.
Judges.
No question.
Hello.
Yes,
Yeah.
sir.
Yeah. So like IBD, that inflammatory bowel disease. So
Yes.
in that, do you know like there is a role of any kind of bacteria in inflammatory bowel disease? Any bacteria?
No, sir. Actually, I am working not on bacteria. I am working how to diagnose it with AI.
So no, you should have a prior knowledge. Like if I'm saying like gut microbiome, have you heard about it? Gut microbiome, gut, our alimentary canal.
Yeah, I have heard about it, but I have not gone too deep on that topic.
Yeah, because AI will give you the predictions and the initial part, but when you need to validate your study, you will have to go deep into it, like inflammatory bowel disease, what is it, which kind of bacteria are beneficial for us, like probiotics or prebiotics, and health beneficial bacteria or some harmful bacteria. So you should know about the basics. Overall, it was kind of good. Yeah.
Very well done, beta. You can leave now.
Okay, ma'am, thank you.
Next is Deepa Ghadi. Deepa, you there? Deepa and Pranali Shetty. Deepa Ghadi and Pranali Shetty. Yeah, I can see Deepa Ghadi there. Please unmute yourself, Deepa. Deepa, Pranali. All right, till they respond, we'll move on to the next. Arka Prabha. Arka Prabha. Kindly unmute yourself, Arka Prabha. Am I audible? Yeah. Please start. Share your presentation.
No, you are not audible.
I'm not audible.
Arka Prabha, Arka.
Ah. Arka Prabha, unmute yourself.
Hello.
Yeah, you're audible now.
Okay.
Share your presentation.
Yes, ma'am. 1 second.
Yeah.
Is my screen visible, ma'am?
Yes, it is. Just put into slideshow.
Okay. So, hello, ma'am. Good afternoon. This is Orko from third year BSc in Ramaya. And me and my team have been working on this a compound called as alpha santalol. So, this paper is on the in silico evaluation of alpha santalol from Santalum album as a potential anti-lung cancer therapeutic. So this is the conformation. We have taken the Z conformer of alpha centinol, and these are the uh, these are the attributes. So what we have done is, uh, alpha centinol is a sesquiterpene, uh, sesquiterpene, sorry, and it's extracted from Indian sandalwood. We have a wet lab team as well, which is working on the extraction part. Our team is mainly concerned about the in silico part. So we have screened almost 50 proteins uh, regarding its efficacy. The bottom ones, the ones here, these are our proteins which fetched us the best results. These 5 proteins. So I don't know if it's visible or not, but this is a literature review, literature study. I'll just shift it here. Uh, Through our literature studies, we found out that in 2022, in the 2022 global census, almost 20% of all the all the cancer issues and all the cancer cases were lung cancer. And sandalwood oil or compounds extracted from sandalwood have immense, potential, and showed they have showed to be very they have proved to be very effective against lung cancer cells, especially this one, especially A549 lung cancer cells. So for that reason, we're working on lung cancer. So, 1 second. The research gap, what we found out is that not many people have worked on anti-lung cancer properties of alpha centinol. Most of what is worked on is about the dermal diseases and skin cancer and these things. So no one really, I mean, there are people who have done work, but it's very rare and it's very sparse about people who have actually worked on alpha centinol in regards to lung cancer. So for this study, we have used Autodoc and Autodoc Vena for the molecular docking part. For visualization, we have used BioVia, Pymol, and Rasmol, and we have used BioVia, Discovery BioVia for the graphs as well, for the plots as well. We used OpenBabel for converting the ligand from SDF format to PDB format. And for the automation part, what we have done is actually we have tried to automate the whole procedure. So you can sequence multiple proteins at once. Usually, when you open up or like when you run Autodoc Vina, you have to do like everything one by one. We've tried to automate it in using PyScripts and BioPython. So what we do is we convert the ligands to from an SDF to PDB format using OpenBabel, and then in one directory we store all the proteins, and we run a Python script which has BioPython in it. So that BioPython script automatically removes the waters and segregates each chain individually and saves it in another directory. And from that directory, another BioPython script removes the head atom, anisome, master, these kind of entries automatically and saves it into another PDB file. Then from that, like those files, those modified files are then ran through another Python script, which adds hydrogen and Coleman charges automatically. Everything is done like one after the other sequentially. Then at the end, those all the prepared proteins are saved in a separate directory from where we launch a bat file, which is a Windows batch file, and that automatically docks everything one by one, all the proteins one by one with the ligand using Autodoc Venom. And then we just visualize it based on the readings, based on the log files. We just visualize it using Rasmol or Pymol and stuff. These are our results. Among all the 50 proteins, these are the top 6 which gave us the best outcomes. And this one 7-MHC had the best one. I think it's minus 7.3. And 7-MHC, yeah, 7-MHC is the best one. These are the 2D leak plots. And as you can see, 7-MHC has bound to so many amino acids here, and it also had the the lowest binding affinity. These are the Ramachandran plots. As you can see here, we have the most activity again in 7-MHC. The hydrophobicity graphs as well. So for the discussion part, as I mentioned before, 7-MHC produced the best results. 7-MHC is actually the extra crystal structure of arachidonic acid, which is and the expression system of it is through SF9 baculovirus system. So yeah, this is an ongoing procedure of ours. We plan to screen more proteins in the future. Up until now, from what we have screened, we got this one as the highest. The best value out of 7-MHC. So yeah, and the reason we are doing this, the future prospect of it, is because screening these things can make it easier for us scientists, even doctors as well, to better diagnose and better treat lung cancer and make it more economical and viable for other people as well. So with that, I conclude my presentation. Thank you.
Judges.
Hello. Yeah, Prabha. Yeah.
Yes.
So your molecular, like the docking study and 3D models which you gave along the lake plots, they're really good. Like you did Autodoc and Autodoc Vina, which is the traditional
Yeah.
docking software.
Yeah.
That's
Yeah.
like you would have learned some of the Python algorithms also along with that.
Yeah.
So yeah, so that's a good way to start your AI or informatics study.
Yeah.
And okay, so can you go back to your that the docking 3D slide, 3D structures of the
Sure, sir.
different.
Sure, sir. 1 second. Yeah.
Yeah. So in this, you are saying like the last one,
MXC.
hello,
Yeah, yeah.
7 mx. Yeah. So it has from. Can you like you told from the leak plot study like it is showing more hydrogen bonding interactions, receptor
Mm-hmm.
ligand interaction, right?
Yeah. Yeah.
Can you say from here the this 3D docking only based on this? Can you say about the binding affinity or the groups where it will go and bind?
Sir, this is the pocket. This is the protein. I mean, 1 second. This is the protein pocket where. Oh, shit. This is the protein pocket where it has bounded,
Okay.
and from the 3D structure, I don't know how to. I mean,
Yeah. So the
say what to
basically the
bind.
answer is you cannot find. Yeah. I just wanted to check you out there. So you
Okay.
cannot find. Yeah. So it's correct. Yeah.
Okay.
And yeah, it was a nice slide. Thanks.
Thank you, sir.
Anishka?
I have one question.
Sure, sir.
Uh, just a minute. The simple question: how do docking score help to determine alpha centennial's potential as a therapeutic compound?
Sorry, sir. I didn't get you, sir.
You have done the docking part,
Yes, sir.
okay? So in respect of this, the how do the docking score help determine the protein that you used alpha synatol's potential
Santalol.
as a
Okay.
therapeutic compound?
So if you conventionally do the screening process, sir, like you have to take each individual cell line and then do like then pipette out alpha centinol into each of them and then do the doc. I mean, and then see if it works. If it
Mm.
inhibits the growth of cancer cells and all. So those things we can do in silico. Instead of in vitro, we can do them in silico, sir. So that saves time, that saves money, that saves manpower, that saves every single thing, sir. So for that, we are doing the study, sir. And not much study has been done in case of in lung cancer, sir. All of the alpha central studies have been done on dermal diseases and skin cancer. So
One more.
we're trying to
Or
doc.
what a key pathway or a protein in which the lung cancer might alpha sentinel target?
So the key proteins, I'm not sure. We're trying to dock different proteins for the docking, I mean, with the molecular docking part. Up until now, we've
Mm.
just done like what we found out is 7-MX is the highest one. I mean, we found the lowest binding affinity in 7-MXC. So with that, we're going
In
forward.
the
We'll do the
docking stage,
GROMAX running.
you must clarify the pockets.
Yeah, so these
The
are the pockets, sir.
compounds which are showing is very less visible.
Oh, okay.
Okay.
Yeah, these are the
Okay.
pockets,
Thank
sir.
you.
Yeah,
Yeah,
so
so to Manisha's question, he has shown the in light green color, I guess,
yeah,
light
yeah.
green color, but they're very small in size. So
Okay.
yeah,
Make the pocket all over one pocket. Then you show the
yeah,
one
so
protein.
so
This is
that
a
the
pocket.
groove will be visible. Hmm.
This is more visible.
Okay, sure, sir. I'll take
Okay.
that into
Thank you.
consideration.
Next
Thank you,
question.
sir.
Nicely done, Prabha. Thank you so much.
Thank you, ma'am.
You can stop presenting now.
Yeah. One second.
Next presenter is Sanjana, GM Sanjana.
Yes, ma'am. I'll present.
Yeah.
I think,
Yeah.
yes, just a minute. Is it visible, ma'am?
Yes, ma'am.
Okay. Good afternoon to everyone. Myself Sanjana. I'm doing my UG second year from Bhavans Vivekananda College, and the paper is about integrative biomarker analysis and predictive modeling on primary biliary cholangitis. And this paper has been guided by S. Chaitanya Kumari ma'am, who's an assistant professor of the Department of Microbiology. Uh, so let's start with the primary biliary cholangitis, what it is. It is a chronic cholestatic liver disease. It is characterized as an autoimmune disease which is leading to the destruction of hepatic ducts, bile ducts. Um, okay. And as seen here, there is, okay, this is a normal bile duct, and then it is an inflamed one. This cholangitis is caused by many factors, that is genetic, environmental, epigenetic, and female bias. The very unique thing about PBC is that it is affecting mostly the female among all the patients, more notly towards the male. Uh, the pathway of primary cholangitis is that first it is triggered by the external factors, then it is going to the T cells. T cells are attacking the epithelial cells of the liver, causing the damage, leading to the fibrosis, to the cholestasis. Because of the inflammation, it is leading to the cholestasis, where the bile secretion that is given all is accumulated, and then it is not able to get rid of that, causing cholestasis. And then because of the T cells getting attacked, the stellate cells are giving out its own secretion, causing out fibrosis. And then this is damaging the liver shape, leading to cirrhosis. And then these structures are being, this prognosis is being observed in the skin has primer spider angiomas. Going to the symptoms, first starts with pruritus. It is a itching that is caused because of the bile salts. Worst sedenites, jaundice, hepatomegaly, edema, ascites, and spider angiomas. Hepatomegaly is because of the worsening of the condition, the liver is getting swelled up. Biomarkers, AMA is an auto antibody, ANA, ALP, and gamma GT, bilirubin levels, because it is increasing because of the bile accumulation, albumin levels, platelet, and prothrombin. So this is the data set that I've taken. The data set, it's taken from the Kaggle. The shape of this data set is 491 columns and 491 rows and 20 columns, where the information is all provided here. I was pretty interested on what is the maximum and minimum age limit of the patients that is there in this data set, which is going up to 78 as a maximum age, and minimum is about 26. As I said before, the common gender that is being affected is female, and male is not very much being affected, shown in the graph. To the age group, mostly middle-aged people are getting affected with this kind of a PBC. And I took this data set and I want to know about how the biomarkers are showing its effects as the conditions gets worse. Starting with the profiling, starts with the bilirubin. Here is a graph that is shown with the stages and the levels. From the earlier stage, there is an increase, a really rapid increase, because of the bile accumulation in the liver, and it's not able to get rid of it, which is shown here. It's blocked bile flow. And then coming to the Kaplan-Meier plot, it's a survival plot with a time and then survivability level, showing both of this high and low. This graph is mainly focused upon how steep the graph goes. If it is going very steep, shows the low survivability level. This high bilirubin level is showing going very steep, showing there is very less survivability level. Starting with one, that is a 100% survivability, going down. Going next to the albumin level, at the stage first, it starts with a good pretty number of level in the albumin, and then by the end of the fourth stage, that's the last stage, it gets down, which is because of the worsening of the liver functioning. Next is the same plot, Kaplan-Meier, for the survival with the time and the probability. This is of low albumin level. As the albumin level goes down, there is a steepness that is seen. Survival is getting low. Next, for the platelets. The first graphs are shown with the diseases, then count. The first stage starts with a good count, and then where the goes last stage, the count is rapidly decreasing. And as a platelet, next goes with the prothrombin time. Prothrombin time is the clotting factor time. If the platelet is getting very less in number, prothrombin time increases because the clotting factor itself is getting decreased. It is clearly seen here. Platelet is getting decreased, prothrombin time is getting increased, and vice versa shown with the survivability graph. Not much difference, but a lower platelet count, there is much of drop that is being seen. And with a prothrombin time, there is a lot of drop, very steep drop, showing less survivability level. Next is that I was curious about the clinical signs with hepatomegaly, spider angiomas, ascites, and edema. And I was curious to know the frequency of it as going with the stages. With the second and
Sanjana,
third, yes, ma'am.
you'll have to conclude now.
Okay, ma'am, sure. Just few slides, ma'am. I'm almost to the end. To the model making, I used model. I put the data in, and then it is made into 80 and 20. And all of these models, and then give a prediction out, which is showing that random forest is the 99%, which is the most accurate one coming up to, and then the next three are tree and then KNN model. With the diagnosis, it can be done by laboratory evaluations with positive AMA, ALT, bilirubin, AMA, with the imaging, with ultrasound, and knowing how the liver is functioning, clinical evaluation and physical signs by symptoms, whatever symptoms that has been seen, and the liver biopsy only if it is needed. Mostly it goes with AMA positive, showing that it's an autoimmune disease, but when it is showing negative, there is a need to take a liver biopsy. Going with the treatment, which is the last one, starts with the prognosis and everything. First starts with the primary first line treatment of UDCA, ursodeoxycholic acid. And if it is working well and fine, the treatment is continued, or else after the treatment is done, it goes with OCA, that is a second line treatment, and then bezafibrates, which are having its own limitations. When the person is not going with the first line treatment itself, they are switched back to OCA and bezafibrates, which are substituting the effects of first line treatments, second line treatments. At the end, all of these are combined if it is very worst at stage. Thank you for the time and interest. That's it, was my presentation.
Judges.
Yes, sir. Am I audible,
The
sir?
presentation
Yeah, yeah,
was
Right.
little bit difficult for me, but
Yes, sir.
concept is new.
Yes, sir. It is
I
conceptually
I
new
need to
and
be
it has a lot of
focused. This was the
information.
second presentation that I make me eager to know much about this. Thank you. But no questions right now from my side.
Sorry, no problem. That's okay.
yeah. So Sanjana, it was a really good presentation, but mostly like as per the AI part is confirmed, we
Yes,
should
sir.
limit more to the informatics part. But as
Okay.
you have told mostly about the complications, the mechanisms, I would ask you a
Yes, sir.
simple question. Which
Sure.
kind of cells are activated in case of primary biliary cholangitis?
Yes, sir. I'm happy to answer this question. First, it's getting with the autoimmune. So it starts with the T cells that are generated by the factors, and it is attacking the stellate cells, the hepatic cells, which is making the inflammations harm itself. Inflammations, then the bilirubin, it's getting just accumulated there. Because of those the levels being accumulated, the cells are also producing its own secretions, causing the stage to go more worse.
See, like you just hear the question carefully. I just told which
Okay.
kind of T cells are activated. Just which kind of T cells.
T cells. I'm not
There
sure
are
which.
different kind of T cells, right? CD8,
Okay.
CD4, regulatory, follicular helper cells.
CDT4 cells, sir, if I'm not wrong.
for like CD4 T cells. Okay.
Yes, sir.
So as your it is based on integrative biomarker. Can you name some
Yes, sir.
biomarkers with reference to CD4 T cell?
Uh, these are the like bilirubin, AMA, platelets, albumin. All these are the biomarkers, sir, which gives out to PBC.
Okay. So I was asking about any CD biomarker, like for T cell biomarker.
Uh, I'm not sure about
Okay, I will just
that,
go
sir.
and have a look around that. Yeah,
Yes,
so
sir.
it was good, like, yeah. But mostly when you attend any kind of informatics seminar in future, yeah, you know the part. Like most of the students, when they are uh, presenting, they are elaborating on informatics as well as the wet lab. But generally, they are going on mechanism part. Okay,
Okay,
so
sir.
that is very good. But for this kind of seminar, you should mostly focus on the informatics part
Yes, sir.
because that will help you in future.
Sure, sir.
Always prioritize the main concept. Yeah,
Sure, sir.
well
Sure.
done. Thank you.
Yeah,
Thank you, sir.
very well done, Bita. You can.
Thank you.
Yeah. Next participant is Deepa. Deepa, kindly join.
Hello, ma'am. Is my
Yeah.
screen?
Yeah, your screen is visible, but not the slides. Yeah, now
Is
the
it
slides are
visible?
visible. Yeah. Go to the presentation. Yeah, good, very good. Can start now.
Okay, ma'am. Uh, Good afternoon to one and all. My name is Deepa Satish Khadi. I am from SMTM College, Nagar. The presentation topic for today is comparison mechanism of antibiotic resistance of Klebsiella pneumoniae and Pseudomonas aeruginosa card AMR and depression. So, the nosocomial
Ma'am, your
infections
video
are
is
the
not on.
infections. Nosocomial infections are the infections that are
Kindly switch on
caused.
your camera.
So her camera is on, but she's not
Camera
seeing.
is on.
Yeah, now it's visible. It was not visible before.
So nosocomial infection are those that are acquired by patients while receiving the treatment in hospital and other settings. Global incidence of this nosocomial infection is 7 to 12%, whereas in India it is quite higher, that is 11 to 83%. The reason being India is still developing and poor infection control and inadequate handling hygiene is seen. As per WHO, 80,000 deaths are seen per year in the predominant report of this infection are pneumonia and sepsis, which we can link to most infection caused in respiratory tract and skin infections. So, ma'am, this
Yeah, what happened, Bita?
slide is
Not
not
proceeding.
moving.
Okay, escape and come out of it. Press escape. Can escape do anything for you? On your machine, there will be escape button.
Yes, ma'am. Now it's working.
Yeah.
This is the distribution of nosocomial infections. The predominant pathogens are S. aureus, Enterobacter, Klebsiella pneumoniae, Pseudomonas aeruginosa, and A. baumannii. This is the percentage at which they cause nosocomial infection, and these are the acquired infections. The workflow is as follows: the use of card and AMF finder for finding the resistance mechanism of Pseudomonas aeruginosa and Klebsiella pneumoniae. After that, we compare the similar and dissimilar mechanism. After that, from the data available, we suggest or predict an antibiotic that is different from any used ones to enhance the treatment of these infections caused by Pseudomonas Klebsiella pneumoniae and co-infection in hospital-acquired settings. So Pseudomonas is major pathogen, major opportunistic pathogen. It has pathogenicity mechanisms and has acquired antibiotic resistance. This is the data which is acquired from frontier from reference papers, and according to the data, the maximum prevalence shown by Pseudomonas is for monobactam, and the least is for aminoglycosides. Similarly, Klebsiella is a gram-negative organism. It has biofilm forming capacity and has antibiotic resistance because of the antibiotic genes expression. This is again the data which has been taken from reference papers, and as per papers, it is said that Klebsiella pneumoniae is resistant to 63% of cephalosporins, whereas it is resistant low resistance is shown to tigecycline and carbapenems. Co-infections. Co-infections are those which are simultaneous infections caused to the host by multiple pathogens. Uh, Klebsiella and Pseudomonas can cause infections like pneumonia, bloodstream infections, UTI, surgical site infections, skin and soft tissue infections. The resistance developed by co-infections is higher than that of their individual resistance, which can again lead to higher fatality. This is the general antibiotic resistance mechanism followed by both Pseudomonas and Klebsiella. They have physical resistance by biofilm formation, intrinsic resistance by having efflux pumps, acquired resistance by having horizontal gene transfer method, and mutational resistance to gene mutation. This is the data which we have acquired from using AMF Finder Plus. Here we have got the gene associated with the resistance mechanism of particular antibiotics, which are used for the treatment of Pseudomonas aeruginosa. This is the software, and similarly we have Klebsiella pneumoniae. Uh, from from the data that was shared above, we have compared the similar and dissimilar mechanisms. Mechanism for fluoroconins and beta lactam, whereas they showed a similar mechanism for aminoglycoside, digicycline, carbapenem, cephalosporins. Then, on comparing, we have a device list of antibiotics which will be more effective for Pseudomonas and Klebsiella and their co-infections in hospital acquired settings, so that it gives result in easy recovery. So these are the antibiotics which were predicted as per the card and AMRF finder, as they not only are effective against MVR but also uh, have many other uses and can be used as uh,
Deepa, you'll have to conclude now.
okay. So we did this for we did Klebsiella and Pseudomonas, as they are more opportunistic and found in HAIs. But these kind of studies and comparison can be done from for other organisms present, and effective drug response can be designed for hospital acquired infections for early recovery. Thank you.
Judges.
Thank you, Deepa. I have two questions for you. One is like, what is the resistance acquiring mechanism for both of these bacteria, for both of these organisms?
Resistance acquired. Sir, they have efflux pumps, and they changes.
I'm saying how they acquire resistance. There will be some method, no, by they which acquire the resistance.
Sir, actually, they have genes. Uh,
Not
for
audible.
fluoroquinones, there is. Hello, sir.
Yeah. Now
Hello,
it's audible.
sir.
Yeah.
Sir, actually, they have genes which
Hmm.
are associated with resistance mechanism. Like in fluoroquinolones, there is mutation in GYRA and PARC gene, and ICE is associated protein with CRP. And this mechanism is seen similarly in Pseudomonas and Klebsiella also.
Yeah, so basically Klebsiella, it's true, the horizontal gene transfer, and the Pseudomonas, as you mentioned, through mutations, porins and all,
Yes.
they both. Yeah. And the second question is, can you elaborate a bit more about AMR Finder Plus?
So AMR F Finder Plus, it is an NBI tool. It is used for antimicrobial resistance finder. It gives complete information about the uh, organism. Then it gives if it is antibiotic resistance or not. It also gives what kind of dosage to be given, uh,
What kind
what
of
kind of dosage to
mutations?
be
What
given.
kind of mutations they take into consideration?
Efflux pumps and intrinsic mutations and resistant mutations are also differentiated, like efflux pumps, and then change in bio.
Okay, okay. So are point mutations taken care of?
So that is not like in deep available on
Okay,
those
okay, okay,
sites.
fine. Thank you.
You have taken a good topic, which is active in all over the India, not only India, all over the world. All scientists and researchers are working on AMR, but this is not much connected with AI or something else. Then okay, it's new. I appreciate your courage. One question, please. What type of resistant gene can be detected using card, what we have used, and AMR Finder Plus? Which type of resistant
Sorry,
gene?
which type of resistance gene, sir?
Huh.
All of the resistance genes can be like if we like there is a search tool where we just click which of the organism we want the information about. The complete information is being shown, like the one where I presented. There I attached this screenshot of the work screenshot of what I actually searched for, and there they shows resistance gene also, as well as the element which is uh, used for the resistant mechanism.
Thank you. Thank you.
Nicely done,
Keep
Deepa.
going. Keep going.
Yeah, now I request Vemula ma'am to join, please.
Yes, ma'am. Hello, ma'am. Can you hear me?
Yes, yes, ma'am.
I'll share the screen.
Yes, please, ma'am.
Yeah. Is it visible, ma'am?
About to, ma'am. Yeah, it is visible.
1 second, ma'am. Yes.
Yes, ma'am.
Yeah. So can I start?
Sure, ma'am.
Yes. Good afternoon, everyone. Myself is Dr. Vemula Vani, working as Associate Professor in the Department of Microbiology, MS Ramaya College of Arts, Science, Commerce, Autonomous, Bangalore. The title of my today's presentation is Fragment-Based Design and In Silico Analysis of Potential HIV-1 Protease Inhibitors. So here basically structure-based drug designing approach had been used in order to develop the potential inhibitors, small molecule inhibitors against HIV-1 protease enzyme. So the HIV virus, as we all know, it belongs to the family of lentiviruses that causes HIV infection or acquired immunodeficiency syndrome. In case of patients with AIDS, what happens is the immune system gradually fails, making them vulnerable to dreadful diseases and malignancies. So the existing treatments for this AIDS disease is antiretroviral therapies, sorry, that is used for the symptomatic management of this AIDS. The problem is it is costly and it develops to, drug resistance. So there is a very critical global need for the alternative therapies or medications. So it is not part of this study. Earlier to this study, we have done some other work in our laboratory in identifying the important or crucial drug targets in case of HIV infection. So we have taken several important proteins of human immunovirus, and we have collected several antiviral compounds from the review of literature, and we tested these compounds against protease enzyme and other important drug targets. We identified that 5 important natural antiviral compounds seem to be very effective against HIV-1 protease. And it was also analyzed that protease is the most important drug target. So with that preliminary information, we went ahead with the further study, which is included here. So for the previous study, iGemDoc was the software used for analyzing the various drug targets of HIV. And these are the 5 natural antiviral compounds: quercetin, barbaloin, aloin, cupriciflavin, and nimbin. So these compounds were used as base for developing the potential inhibitors against this HIV-1 protease. So as we all know, structure-based drug designing is the approach where we use the 3-dimensional structure of the target protein is used for designing the potential inhibitors against the organism. Here it is HIV-1. And lopinavir is the compound which is well characterized to be potential inhibitor against this HIV-1 protease. We have used this one as the reference compound for this study. So here, this is the protein structure, HIV-1 protease, which is used as drug target for this study, which is retrieved from the 3-dimensional structure, which is retrieved from protein data bank with the ID 8DCH. The objective of the study is to design the potential small molecule inhibitors against this HIV-1 protease using fragment-based approach. And after the designing, these molecules were analyzed for the druggability of the druggability using the in silico methods, like their binding affinity, pharmacokinetic properties, toxicity, other parameters were checked using the in silico methods. The hardware and software used, the workstation with higher configuration was used, and then the operating system we worked with is Windows 10 Pro. And the software what we have used for this analysis is Schrodinger Maestro 12.5. And we also used Osiris Property Explorer Protox 2 server for predicting the toxicity of the molecules. And Swiss ADME server is used for boiled eggplant analysis. So the target protein structure, as I told, it is the protease of HIV-1 with the PDB ID 8DCH, and it is a crystal structure of highly resistant HIV-1 protease from the clinical isolate of this PER10X with GRL0515 ligand. It's a complex structure. And then the protein preparation was done using the protein preparation wizard of the Schrodinger software, and the receptor grid generation module was used for defining the grid. So we have taken these amino acid residues mentioned here that constitute the binding pocket of this HIV-1 protease. And ligand structures, those 5 ligands, natural antiviral compounds which were specified earlier, these compounds were retrieved from PubChem database in SDF format, and later these compounds were converted into Mastro format for the next step of analysis, that is fragmentation. So the LigPrep module of Schrodinger soup was used for preparing these ligands, and energy minimization of these inhibitors was done using the OPLS potentials 2005 force field. And as I told, lopinavir was used as the reference compound for the entire study. Then the very first step in this generation of molecules is fragment generation and breeding. Fragment generation, what we do is, we take these 5 compounds which were identified, and it is fragmented using this fragment module of the Schrodinger. So the PowerShell fragment .py script was used to generate the fragments. So this fragment generation that resulted in 219 fragments. All these fragments were subjected to docking by using the glide module of this Schrodinger. So among all these fragments docked, only the fragments that showed lower binding energy compared to the reference compound lopinavir fragments were taken for further consideration, that is for breeding. In breeding, what happens is all these fragments in different combinations were joined together in order to make the novel compounds for which the breed module of the Schrodinger was used. So it creates the novel compound. So totally 208 novel compounds were produced out of these 143 fragments. And these compounds then, based on their docking score, we have sorted them out. We have selected the top 10 compounds showing the less docking score than the reference compound were selected. So this is the 10 compounds that were identified, and these compounds were further analyzed. So in this list, here we have also included the reference compound lopinavir.
You'll have to conclude now.
Oh, is it? Okay. Okay.
Yeah,
These
yeah.
are the 2D structures of 10 novel compounds from which fragments they were generated. Fragment 1, fragment 2. This is MMGBSA analysis that predicts the binding free energy. 8 compounds were showing to have the lower binding energy than the reference compound. And this is ligand interaction diagram for all the 10 compounds that were identified. So when we look at this ligand interaction diagram, all these compounds show better interactions in terms of hydrogen bond and hydrophobic interactions in comparison with the reference compound, that is lopinavir. Then ADMET analysis was carried out using the quick prop module of the Schrodinger. This predicts the pharmacokinetic properties, and finally the toxicity was predicted using the Osiris property explorer and Protox2. And egg plot analysis was carried out, boiled egg plot analysis was carried out using the CCADME server. So with all this analysis, finally, we have concluded 3 compounds out of these 10. Compound 4, compound 6, and compound 7 were identified as most potential inhibitors of this HIV-1 protease. So here we are showing the 3-dimensional structure of these 3 novel compounds in complex with the target, that is HIV-1 protease. So the summary and conclusion, all the steps are shown in the form of flowchart. The natural compounds from PubChem, the target from the PDB, receptor grid generation, fragmentation, XP docking, fragments, breeding, and then 10 compounds. These were subjected to MMGBSA, ADMET, boiled egg plot analysis, 2D interaction. Finally, 3 compounds, novel compounds were identified. So these are the important references used for this study. And acknowledgement, I would like to thank the management of our college for supporting this project. And I also thank the principal, head of the department, and other faculty, who were like their support and for their support and cooperation during the entire course of this work. Thank you.
Judges.
Hello, ma'am. Like it was a quite extensive study,
Yes,
and it was dealing with lot of parameters. So I have a question that you told about the breeding. Post breeding, there were 208 novel compounds, following which there was 10,
yes, right.
and finally 3. So what was the
Correct.
novelty behind them? How are you classifying them as novel compounds? Based
Because
on what?
yeah, correct. So we had a doubt that what if these compounds are already existing in the databases. We have done the database search of these compounds against PubChem and also Zinc database. We have found out that all these 10 compounds were novel.
Okay, so that means they did not have any kind of significant similarity with previously published published
Yes.
whatever compounds. Right?
Yes.
Yeah.
Right. Correct.
Good. Yeah.
Hello, ma'am.
Hello, sir.
How can the fragments-based drug design, improve the efficiency
Yeah.
of discovering new HIV drugs? Because HIV already changes conformation. How it helpful?
Right. Now that is what, sir. Since it changes its very fast mutations, it develops resistance against the already existing treatments. We are trying to come up with the novel combinations. We have taken the base from the already existing compounds in different combinations. When we build the molecules using this software, the expectation is the novel compound so that they will not have the resistance against the virus.
Okay.
And that is what, as I answered to the question of the other judge, we have also searched the databases and found that these were not existing in the database, which means that these could be novel compounds. And later we tried to find out their binding affinity and other parameters so that they can be used as drug molecules and they have the properties of the small molecule drugs.
You go for the molecular dynamics?
Yeah, actually, that is the step remaining, sir. We are working on it. There was some issue with the software, GROMAX. So we are trying to fix it. At the very next
So
step
100
is that only
nanometer,
it is
100
on.
nanosecond or 1000 nanosecond?
No, 200
Which you
nanoseconds, sir.
prefer?
Here we have done the similar
Huh?
study for the HPV virus. Human papilloma
Oh,
virus also, I have done the similar study. So we have done for 200 nanosecond using GROMAX.
oh, thank you.
Yeah, yeah.
Nicely done, ma'am. Thank you so much.
Thank you, ma'am.
Now I invite Ms. Sukhwinder Kaur.
Yes, ma'am. I am here. Dr.
Yeah, ma'am.
Sukhwinder from Punjab.
Welcome, ma'am.
Okay. Actually, I've worked very less on the Zoom.
Ma'am, share and then you keep open your presentation and then share via Zoom.
You have already shared, ma'am. Just now go to the presentation mode.
Okay. Can you see, ma'am?
Yes, ma'am. Ma'am, on the top there is a
Yes, yes.
slideshow. Yeah, ma'am.
Okay, okay. Is it clear, ma'am?
Yeah, all good, ma'am.
Okay, okay. So it is basically a review paper, not a research. So it is I am just highlighting about the role and application of artificial intelligence based tools for the diagnosis and prediction in the healthcare sector. So artificial intelligence is nowadays a very good way to provide a better health services. And it is a but complex, but it is mainly transforming the medicines by the improvement in accuracy and efficiency of the clinical decision making. It is lowering the errors in the diagnosis and enabling the treatment plans to be better and the better health record administration. So there are the various applications of the AI in the health sector, right from the medical imaging diagnosis, for the physicians, for the research and development, just as in the drug designing, vaccine development, in the patient care, in the real-time patient prioritization, in the pregnancy management, and other sectors. So in the medical diagnosis, the AI-powered tools are now detecting the anomalies in the X-rays and CT scans. In the radiology section, in the conventional neural networks, they are essential for the imaging and detection of the illnesses like the brain tumors. And the deep learning algorithms are processing about 1,000 images per minute. That is far more than the human beings which they can do. Then the AI models in the pathology are differentiating between the benign and the cancerous cells. So this is also helping one. And the tools are examining the skin lesions and the moles also. So when we talk about in the cardiology, the machine learning models are now studying the electrocardiograms and the patient histories for detecting the heart problems with the accuracy. So it is helping in the eye problems also, in the early detection of the diabetic retinopathy. And the softwares are now improving the accuracy of the patient diagnosis. So when we talk about the treatment also, not only the diagnosis, in the oncology, the AI algorithms are now examining the genetic mutations with the tumor biomarkers for the determining the most effective therapy. The cardiovascular diseases are also being treated with the help of AI by wearing the devices which are describing the tailored drugs, the continuous heartbeat, the way of the heartbeat, how the heart is working, that can be calculated and monitored. Similarly, in endocrinology also, the AI is helping in the continuous glucose monitoring for the diabetic patients. So there are the various digital health monitoring now with the help of AI. So that is having the readmission risk prediction can be done. The personalized treatments can be done in the ICU also, in the inpatients also. And after the patient is relieved from the hospitals, now in surgery, especially in the orthopedic sector, we have seen that the robotic assisted surgery is now getting a propellence and is getting a better response. So in the medical condition forecasting also, the drug discovery. So when we talk about it is also helping in the operation and the patient management in the hospitals. There is the AI powered systems are using the natural language processing for the automation of the data entry, for assessing the information and briefing the patient notes, that is helping the doctors in that. So virtual assistants, as we see in like the chat boxes and the virtual, they are giving the 24-hour support to the patient, that whether the doctor or the nurse is nearby or not. So that is also reminding about the appointment schedules. The patient care is also being looked after with the help of the machine learning algorithms. So, but there are some challenges also which the AI has to face. So it is beneficial and fast. Still, there are the number of obstacles. The major one is the data protection and the security, because mostly the medical line, everybody wants that the data should be privacy, and the security should be there, and especially the high profile people. So there should not be any type of breach which can result in the theft of that and the misuse of the personal health information. And for that, the fairness of the AI models should be there, and they should be trained exclusively for that. And sometimes the AI models are made for targeting a particular race or a particular group of people. So they may not perform well on another type of people, because they have been made for keeping in view the genetic makeup and the other things which are popular in that particular race group. So they may not be applicable to other ones. So the future of the AI is there, very good, but it is likely to expand. But it should be designed that the accountability of any consequence of its application should also be kept in mind. And the continuous research innovation is important for unlocking the future potential, whether it has to grow further or how deep it can go. So with its successful integration, it is anticipated, no doubt, to revolutionize the whole of the healthcare and for the better improvement of the patient outcomes. So ethical considerations should also be there, because they provide the inaccurate diagnosis sometimes, which then in that case, which one is to be blamed? Whether the development of that software or the healthcare professional or the institution which is applying that AI. And the main thing is that it should supplement but not replace the human decision, because making the insurance of the physician and maintaining the control is important. So regarding this, the ICMR has given a very good guidelines that should be followed strictly. In the 2023, they were given. So that should be followed strictly for that. Thank you.
Judges?
Hello. Hello.
Yes, sir.
Filter ma'am.
Yes.
Hello ma'am. It's nice presentation. Do you know something, some tools or technique regarding this healthcare diagnosis AI tool?
Yes, so there are some softwares which are the simple one, which we can see that we are having a wristwatch that is calculating our heartbeat and heart rate, and that can regulate that how much pulse rate is going on, how much stress we are having. So this is the simplest AI tool which is popular in the smartwatches nowadays. But I am not basically from the computer engineering background, so that is why I don't know much, sir.
Okay.
Sir? Next question, judges.
No questions. It was a good presentation.
Yeah. Thank you so much, ma'am. Appreciate it.
Okay, thank you, ma'am.
Yeah. Now I think this was the last presentation for the day. I would just like to sum up today's event in a nutshell if you can bear with me for 10 more minutes. We started today the sessions. I will say it was a roller coaster where we saw that artificial intelligence is the new frontier in biological discoveries. We started with a short and sweet message from our principal, Professor Dr. Dinesh Kala. He very briefly told us that because we are in AI generation and we are dealing with biology, we are encompassing the entire world in the palm of our hands. The same sentiment was echoed by convener of the conference, Dr. Ranjana Khare, through her talk. We had Dr. Devjani Dasgupta in her inaugural address emphasizing that biopharma rules the roost with the assistance of AI. She was also supported by Dr. Sarita Mahajani in her plenary session, where she prophesied that the double helix gave us the script of life, whereas AI is becoming the reader, the editor, and perhaps even the co-author of that script. I thought this was what I was going to experience, in thoughts of the glamour, the galaxy, but no. The technical session was a gift, a bouquet, where the UG, PG, PhD scholars and faculty gave us the peak of AI with respect to foundations of AI in biology, touching the aspect of artificial intelligence and machine learning in study of basic life sciences, computational biology and bioinformatics with respect to past, present, and future, the big data in biology and the challenges and opportunity that we face. Thereafter, some of the participants spoke about the in silico models and biological systems, discussing molecular docking and drug discovery in silico, AI-driven genomics and proteomics, systems biology, wherein modeling pathway and networks was discussed, precision medicine and virtual clinical trials were discussed. We had participants and certain faculty members talking about AI in healthcare and diagnostics, wherein deep learning in medical imaging and disease prediction was the future of biology with respect to AI. AI, according to some participants, is also useful in early diagnosis of cancer, diabetes, and neurological disorders. Not only that, we can say that we will be touching more of human biology with the help of AI. In case of certain participants, they have proposed a future perspective with the use of quantum computing in biology, synthetic biology and biotechnology, and maybe someday AI-powered biology for humanities. I found that basically when it started, I never thought that my process of thinking will be anywhere other than botany, because I'm a botany teacher basically. But this has opened my mind to various aspects that can be achieved through AI. I'll take this opportunity to thank our esteemed judges, both of whom have sat through all the presentations, keenly observing, keenly pointing out, keenly guiding. I could not ever imagine that about 17 to 18 presentations, and you both have taken each and every aspect of it in the same enthusiasm that you started with the first. And though we ended at the last, but it was as though you had started with the first again. So I'm very much thankful to Dr. Manish Kumar and next to be the Dr. Rohan Raj Roy. I'm keeping my fingers crossed for that soon we'll be calling you Dr. Rohan Raj Roy. But I'm really thankful that you both, did not let us feel that the participants, you and we, were something different. You encompassed all us together, thinking that this was one session where we were supposed to learn from each other. I take this opportunity to not only me, but along with my conference committee members, our convener, Dr. Ranjana Khare, who has been at the helm of this right from the beginning, take this opportunity on behalf of R.K. Talreja College to appreciate all the involvement all the participants have shown for today's session and made us too happy to speak of any few words. Ranjana ma'am. Ma'am, you're on mute, I think.
Yeah, superb compilation of a whole day in 5 minutes, and that was actually great way to sum up the day. But truly, it is an honor to have both our judges and how patiently, keenly they have gone through each and every aspect. Hats off to you and thank you so much. I really don't have words to thank you enough for your dedicated, attentive, and at the same time, uh, just giving your insight in all the aspects of the participants' work related to AI and in silico work. Thank you so much. I would really like to have you all the time, whenever in future we gather any kind of programs. It is great to have you all. Uh, really appreciate. Finding short of words. And Meena madam has done this job of putting everything together is really, really commendable. I mean, thank you so much, everyone. So we have come to an end of the day, and I think judges need to mark out. Madam, you will continue with this?
Ma'am, you can, sure.
Yeah, okay. So I think we want at least one topper from each list, each category rather, UG, PG, faculty and PhD together. And if you feel you want to give separately also, that's also fine. But at least we want from each category the best presenter for today. And maybe you can keep that ready because the result we are going to disclose tomorrow, not today. But you can sum up now, I think. We would like to hear from judges.
Yeah, please.
Yeah, so ma'am, like both Ranjana ma'am and Meena ma'am, and also Nisad, thanks for giving me this opportunity. Like it feels really nice and overwhelming when you are in the third year of your PhD and you are being called to the advisory committee and to judge like fellow UG, PG mates. So yeah, it was a very good experience, and overally, I am so happy with all the participants. Like each one is kind of a winner in their own because UG, PG, PhD faculty, whoever delivered, they were so keen on AI, on informatics, and how this new age AI is coming into consideration. So mostly, I would like to say that AI is the benchmark for prediction for like precision. Like if we want to do disease modeling or any kind of outbreak, or viral virus outbreak, or any kind of new virus which is forming any disease and all. So first we need to predict. So that prediction comes with AI, and mostly the AI findings shall be validated through in vitro and in vivo studies, also human studies, because AI will give you the first line. Second and third, it should be through in vitro and in vivo. So uh, we should put it all together, and then the icing on the cake is AI. Because I work on Zika virus immunology, so mostly my first objective is based on immunoinformatics, but next all is on the wet lab. So yeah, it's a very good like opportunity and very good webinar. So we could dwell with each other and interact. And all participants, I congratulate each one of them. Like there will be one winner from each category, but each one is a winner in itself to present at such a young age and do it so nicely. Thank you. Thank you.
Thank you, ma'am. Thank you, all of you.
Manish sir is, sweet words, very few words.
Actually, I'm not speaking much. Uh, Of course, you are all are new people to me, but Dr. Ranjana and Dr. and Mr. Nisar, he both contact me for this opportunity. I really thank to him and Dr. Meena, ma'am, you are so auspicious for me because you are the first one that attract attract this conference and coordinate all of them very nicely. Thank you. And in future, I will be with you all. And I learned many things from this seminar also. Thank you.
The Parinita ma'am.
Yes, ma'am.
As organizing secretary, Parinita ma'am is our organizing secretary. You have any observance for us?
I was just mesmerized by different varieties of presentations. So I was also thinking, just like
Mark,
you,
this
how
is
to
also
incorporate this to our subject.
actually Mark's 3-2 presentation which mesmerized me, and this is only this, all the news ideas.
Yeah.
One from Khushi Solanki and GM Sanjana. Thank you.
Thank you, sir.
So it seems we are at the end of the road for today. I request all of you to fill the feedback links that have been posted either here or in the group. I request all of you all to join us tomorrow at 9:45 a.m. again. The remaining presentations and the plenary talk tomorrow will start from 10. Please join us in this journey. If today has been any example, I think tomorrow's will be the actual movie that we will be seeing. So please be with us. With Ranjana ma'am's permission, can we conclude today?
Yes, ma'am.